It's a pleasure, a really pleasure to be here. And it's wonderful to actually watch collaborations. I was very enthused in seeing Jonathan's presentation about the wonderful people who have come together from a very diverse network of different societies and organizations, and now from innovation, as Dr. Goel exemplified. I'll take 20 minutes of your time this morning to frame the issue of advanced heart failure. And I took some poetic license and changed a component of the title, if you've noticed, and that is to say, what is it and what can we do about it? Because it is on the rise, and that's easy enough, and there's no point in dwelling on that. Part of the reason why it's on the rise is that we recognize it better. And another reason why it's on the rise is because we're doing better on the pre-advanced stages of heart failure and preserving the residual syndrome, which then ultimately leads to a large section of advanced heart failure. Now, the notion of having a heart failure congress here is very germane today because this year, 2017, represents the 50th year anniversary of heart transplantation, perhaps the most iconic therapy for patients with advanced heart failure. And it all began at the Groote Hospital in Cape Town, which translates, I think, into Big Barn, and there's nothing Big Barney about it, on December 3rd, 1967. So later this year, the actual event will be celebrated. This is what was on the back cover of Life magazine. Interestingly enough, when they exemplified the first transplant, on the left is Lou Washkowski, the recipient, and on the back cover was Marlboro. And it was amazing. I have the actual Life magazine in my office, and it's amazing to watch. Every second or third page has either tobacco ads or Scotch ads. Now, when you start thinking about advanced heart failure, you have to think about advanced heart failure in two competing parallel pathways of therapeutic opportunity. The first relates to neurohormones, cytokines, and growth factors, and certainly this sectional pathway is well known to all of us, and there is evidence of the credit that we have in our field as a result of tackling the targets in this particular pathway. And we can review those in a summary slide here, but we also know that there are limits to pharmacological therapy in patients with heart failure and reduced ejection fraction. So we began from a highly motivated set of transition points in treatment of heart failure, where we were first able to demonstrate disease modification with ACE inhibitors. And then we added beta blockers, and then we added mineralocorticoid receptor antagonists, and then we got a little brave and said, why not stack on even more and ameliorate every potential target? And then the data gets rather murky after that. We tried a drug called omapatrilat, which is really a precursor to Entresto, that did not work. It was an ACE inhibitor and a NEP inhibitor. We tried etanercept, which is a TNF-alpha antagonist, and that didn't work. We tried endothelin antagonists, which seemed to work extremely well in the right heart syndromes, but not at all on the left heart. We tried Zamotrol, and then we tried clonidine-like analogs, moxonidine, which is a centrally acting agent, and none of them worked. And in self-selected African Americans, we saw some attributes from a positive standpoint with hydralazine and isosorbide dinitrate, and how that fits into our daily armamentarium still remains somewhat controversial. We have a number of ineffective therapies: erythropoietin for anemia, warfarin for thromboembolism in sinus rhythm patients, SSRIs for depression, statins once the heart failure syndrome is manifest, they don't seem to work. And we have two potentially effective therapies in the form of fish oil, which has been tested in the GISSI heart failure trial, and then ivabradine, which has certainly shown promise in patients with heart failure and reduced ejection fraction who remain sympathetically activated despite beta blockade with heart rates above 70. And now, of course, we have replaced the first agent with ACE inhibitors have been replaced with the class of agents ARNIs, which are angiotensin receptor blockers and neprilysin inhibitors. And I think that these clearly represent the first advance that we have, again, in saturated management from a pharmacological standpoint of heart failure and reduced ejection fraction. But what I want to point out to you is the illusion of stability in heart failure, and that there is a growing number of patients with advanced heart failure that perhaps we don't recognize early enough. So if you look at the data from the ARNI literature, the Paradigm HF trial, here's interesting insights from that. It turns out that 20% of so-called stable patients who were never ever hospitalized for heart failure would have a primary event in follow-up. About 17% of these patients died during the 2.5 years of median follow-up in the trial. And of stable patients who experienced a primary event, death preceded heart failure hospitalization in half of them. And that's a very serious issue. And most of these deaths were obviously sudden cardiac deaths. So this illusion of stability has to be kept in mind as we think about advanced heart failure. And a good way of notionally expressing this early stage in heart failure as patients are advancing is to think about this algorithm that many of us have promulgated in the literature. And this basically posits that when you see your patient, first ask the question, how are the symptoms controlled? Is their quality of life good? Have you ensured optimal medical therapy? But then there's a very important question to ask, and that is, does your patient meet criteria for increased one-year mortality? We rarely ask that particular question as we are seeing patients. We are very satisfied in the expression by patients that, oh, well, I'm feeling so good, thank you so much, and here's an apple. And we should really move one step ahead and think about whether there is an illusion of stability in these patients. And how can you pick up these patients? Well, there are a number of different bulleted criteria here, and I'll emphasize a few. First of all, smoldering hyperenemia, which is exhibited by a persistent hyponatremia, is a particularly important sign on labs. If patients are requiring less and less ACE inhibitors or beta blockers as a result of the need to maintain their blood pressure, that's a pretty bad sign. If patients are being hospitalized repeatedly, that's a bad sign. If patients are requiring more and more diuretics in a stepped manner, that's a bad sign. What's the point of telling you this? The point of telling you this is that please focus on this question as you examine your patients, particularly looking at the longitudinal aspects of the temporal sequence since your last visit. Most of us fail to do that. Now, let's move on to the next pathway, which is the mechanical stretch pathway. And this is a completely different pathway that determines residual left ventricular dysfunction and its phenotypic expression in advanced heart failure. And we therefore must tackle it through a different paradigm. The paradigm is not one of neurohormonal growth factor or cytokine targeting, but it's a very different way of targeting it. And I call that particular targeting Laplace therapeutics. Laplace's law is a law of physics that posits the stress and strain relationship between a chamber, its size, the pressure exerted in a chamber, and inversely with its wall thickness. So we have a series of different ways of maneuvering around this and tackling Laplace therapeutics in patients with advanced heart failure. And the classic prototype of this that has withstood the test of at least the current 4 decades is that of ventricular assist device therapy, where you completely diminish the pressure within the cavity. But there have been attempts to remodel the ventricle, such as the Door procedure, the Batista procedure, and they have not really worked. There have been attempts to try and remodel the heart by putting a jacket on it, like the Acorn jacket shown here, and that has not really worked well. There have been maneuvers to try and take very large ventricles and convert them into bilobed structures by skewering myosplints into them. I've been in at least 4 4 of these operations, and every time I've walked out, I've said, boy, that's a myo kebab. It's not a myo splint, and it's unlikely to see the light of day. Cardiac resynchronization therapy has a way of tackling myocardial stretch and strain in a very different manner, and it has a seat of its own. It doesn't necessarily address Laplace's law in the traditional way. And then finally, the whole modus of cell therapy is emerging as a way to increase scar thickness, if you will, and modulate Laplace therapy in that manner. So this is a very quick distillation of what's out there, and I'd like to spend the last few focus of this presentation on the evolution of the field of ventricular assist devices. Just like your smartphones that all of you admitted to having at this moment, and the stuttering in its innovation, ventricular assist devices have gone through a series of innovations, but the main innovation has been a gradual miniaturization of this technology. So what has been the basis of that miniaturization? I mean, there's always a reason for miniaturization, and the basis for that miniaturization has been this very important shift in our thinking from the need for biomimicry to accepting an unnatural physiology. And let me explain that to you. So, of course, we said if the left ventricle fails, we need to assist it. In order to assist it, we need to assist it with a displacement chamber type device. And what happened with that is that the need to re-establish pulsatility created large, bulky devices that had valves in them which lacked durability. And so those first generation devices did not see the light of day until a NASA engineer really gave us the idea and said, wait, why don't you use jet propulsion type technology and use standard continuous flow? And that, of course, we said is an unnatural physiology. You know, would you render us non-pulsatile? How could you do that to us? And it turns out that that has allowed for the field to express itself in a very clear way. Of course, we pay a price for that, and we'll talk about some of those. And the price that we pay is depicted here. The price we pay is that we create progeria of circulating blood cells. What does that mean? That means that we rapidly age the blood elements as a result of this unnatural physiology. And when we rapidly age them, the way in which these cells, like red cells when they die off, or white cells when they die off, or platelets when they die off, they are actually removed by the reticular endothelial system in the form of microparticles. If you accelerate aging, these particles develop in a much, much more higher concentration. And it turns out that in the microvasculature and also upon the macrovasculature, these microparticles exert very strong oxidative stress signals. And this really results in many of the syndromes that we now see as a result of this unnatural physiology. And we'll go through one of them next, which is acquired von Willebrand syndrome. So back in 1955, a gentleman, a primary care physician by the name of Hades, posited in a letter to the editor in New England Journal of Medicine that he had seen for a decade the association of gastrointestinal bleeding in patients with critical aortic stenosis in his practice. And he said, well, you know, I write this letter to let people know that there's this association and let them really establish the scientific basis of it. And it turned out that the scientific basis of that very low pulsatile circulation and microvascular dysfunction in the gut was the development of acquired von Willebrand disease, where the high molecular weight multimers of von Willebrand factor are sheared as a result of this unnatural physiology, especially this continuous flow. And we see bleeding complications as a result of this with most of the currently available devices. Shown here is the Heartmade 2 and the HVAD hardware device, and both of them show similar levels of shearing of this syndrome. And it turns out that this unnatural physiology creates a very complex weave of hemocompatibility-related problems for us. And we see not only gastrointestinal bleeding, but we see a high prevalence of strokes in these patients for as yet misunderstood mechanisms. We don't know it. It's very, very difficult to sort out this issue. And then we've seen this issue related to pump thrombosis, where there's hemolysis and the pump itself starts to clot. And whether it's a hardware device or whether it's a Heartmade 2 device, there's a rate of somewhere between 6 to almost 10% of encountering this particular complication. And there's a dynamic equation. If someone bleeds, then we back off anticoagulation, we create more thrombotic milieu, etc. So there are, of course, clinical factors that govern this. Now, let me quickly go over current randomized controlled trials in ventricular assist devices, and I will share with you 3 trials: the Endurance trial, which is a large trial comparing the HVAD device to the Heartmade 2 device in transplant-ineligible patients; the Endurance Supplemental trial, which was done as a follow-on to the first trial, and I'll show you why; and then the Momentum 3 trial with the novel Heartmade 3 device. Now, Endurance was a large trial, about 400 patients, randomized 2-to-1 to the HVAD and the Heartmade 2. And what this trial really showed us over a 2-year period in this older cohort of patients, the mean age was about 64 to 66, is that hemocompatibility-related problems are huge. We see a lot of gastrointestinal bleedings, we see a lot of pump exchanges, and we see evidence of stroke. Curiously, in this trial, the stroke rates with the HVAD device were very high, almost 27 to 30% with this particular device over 2 years, as compared to about 9% with the Heartmade 2 device, which is the standard. We all believe if someone says, what's my chance of having a stroke, we say about 8 to 10% is the correct way. But this particular device had a much higher rate of stroke in this study, which is why the Supplemental trial was done. A Supplemental trial enrolled a further cohort, and the only difference was that there was very close attention to blood pressure management in the HVAD group, but not in the Heartmade 2 group. And even the Supplemental trial, which was presented just a few weeks ago at ISHLT, showed 2 things. First, it did not meet its non-inferiority endpoint, which was preset, unfortunately, suggesting that the stroke rates are still higher with the HVAD device compared to the Heartmade 2 device, despite blood pressure modification and intensive blood pressure management in that one arm only. Curiously, only one arm was subject to the blood pressure modification. But it did show that the overall stroke rates at 1 year were decreased with this particular management strategy. Whether it just shows evidence of a learning curve or whether it actually shows the impact of blood pressure reduction remains uncertain, and this trial has only been presented in abstract form. The Heartmade 3 device is a novel device that is in fact now available, and I've been signaled that I need to move quickly to stop, and I will in a few moments. This device is a magnetically levitated rotor pump. It's frictionless, has wide blood gaps, and it does not, in fact, have the problems of hemolysis as the other devices do. So I'll quickly just show you 2 points. The first is that in observational data, there is less shearing of von Willebrand factor with this device. With the Heartmade 3, there's more preservation of the high molecular weight multimers. The second is that in the Momentum 3 trial, which we have now conducted and presented its first stop endpoint at 6 months on the first 300 patients, suggested superiority of this particular device on the endpoint of survival free of disabling stroke or reoperation to remove the pump. Almost all of the benefit was from the absence of pump thrombosis here. No difference in disabling strokes and no difference in survival at the 6 months. Very quickly, exoorganoplasty is a field that you should keep in mind. This is basically using biomaterials to strengthen myocardium, and there is a trial called the Augment HF trial that's ongoing with alginate hydrogel that's looking at this. Neurocardiac modulation, I won't go into the details of this, keep that in mind as we move forward. And finally, the promise of genomic and cellular therapy, which we were all really enthusiastic about with circa 2A manipulation using a viral vector, was unfortunately not met. So the future is in recovery and regeneration. We have an entire plenary session subsequently on it, and I won't go into it, but all I will leave you with is that the hype is greater than the immediate hope in this field of myocardial regeneration, and we should all remain cautious. Thank you for your attention.